Thank you, Professor Simoni. Also from my part, welcome to everybody here. And now we shift our focus to the male, and we will put our emphasis on male infertility by providing also a new classification, the APHRODITE criteria, or APHRODITE classification that will be, hopefully in 10 years' time, what the Poseidon is for females. These are my disclosures. So let's start by looking at some facts and figures. We know that both partners contribute to the etiology of infertility, so both female and male factors are important when we evaluate a couple with infertility. And we also know that about 20 to 30% of cases can be attributed to male factors only. We also know that suboptimal sperm parameters are not uncommon. About 2% of men present with abnormal semen analysis. But at this point, there is still a low detection of male factors and a low diagnostic yield of male etiology of infertility. And I think first thing I want to emphasize is that a thorough workup of the male partner, an andrological evaluation of the male partner is absolutely necessary when we are managing and treating couples with infertility. We also know that sperm count is declining at an accelerated pace globally. So in 1973, the mean sperm count was about 100 million per milliliter. And in 2018, this has decreased to 49 million per milliliter. This is a worldwide phenomenon, so this is based on data from all continents. And we also know when we look at the sub-analysis of the last 25 years, that from 2000 to 2018, this decrease in sperm count is happening at an accelerated pace. So it's really important also that we look at the men because over time we see that sperm count is declining. I think what is the etiology of this phenomenon is still not very clear, but I think it really is a message to us that we do not forget the male, that we really look at male factors, and that we also don't stop after the semen analysis, but then we also look at other aspects that we can evaluate in the male and maybe potentially treat or improve to also improve sperm quality and sperm count in men. Now, when we talk about normal spermatogenesis, we know that there are several factors important for normal spermatogenesis. First phases of sperm development from spermatogonia to spermatocyte are really dependent on signals of FSH. And then the final steps are more dependent on testosterone. Testosterone is produced by the Leydig cells in the testis under influence of LH. And it's really also important to know that the intratesticular testosterone concentration is about 50 to 100 times higher than serum testosterone levels. And it's really this high intratesticular testosterone locally produced by the Leydig cells that is also important in supporting normal spermatogenesis. So you have in one part FSH-dependent action on Sertoli cells, but also LH action on Leydig cells producing these intratesticular high testosterone levels that are also important for normal sperm development. If you put this in a schematic overview, you can see that the Sertoli cells stimulate spermatogenesis under the influence of FSH, and that LH is important for testosterone production. There is negative feedback with inhibin B or with testosterone in itself to the pituitary gland, regulating FSH and LH concentrations. However, we know from physiology that both FSH and LH are important for normal spermatogenesis, both quantity and quality. But the question arises, can we use gonadotropins to influence or to stimulate spermatogenesis? Can we use this knowledge to our advantage to improve sperm concentration and sperm count in men? We have some rationales, some ideas why it could be useful to use gonadotropins in male infertility. We do use it in men with hypogonadotropic hypogonadism. There is standard of care. There is also some data from animal studies that in primates spermatogenesis is not running at its highest capacity, and that extra FSH stimulation may be useful to stimulate spermatogenesis over baseline. We also have some off-label use of gonadotropins of FSH in men with idiopathic infertility, so without having a clear etiology of the infertility. And we also have some data on off-label use of SERMs, selective estrogen receptor modulators, and aromatase inhibitors to increase endogenous gonadotropin production by influencing the feedback on the pituitary gland and the hypothalamus. Both these use of gonadotropins in idiopathic infertility and of SERMs and aromatase inhibitors are off-label. So it's really a question which patients can benefit from gonadotropin stimulation, what is the optimal treatment approach that we can use, which are good endpoints to study the efficacy. So we need more clinical data, more clinical studies using gonadotropins in infertile men. And that was the rationale to put up the APHRODITE criteria for the APHRODITE project. APHRODITE is short for addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. So it's really looking at men with idiopathic infertility and then see how can we better stratify, classify these men, that we don't put all men with infertility in one box, but that we also try to identify subgroups that can benefit from specific treatment. The APHRODITE criteria are based on standard clinical patient parameters that we obtain in our routine workup and routine laboratory tests, and that we hopefully can use to better stratify infertile men that can benefit from hormonal treatments. The APHRODITE criteria were developed under the leadership of Dr. Esteves and in a working group with experts from reproductive medicine, gynecologists, urologists, endocrinologists, andrologists. And so the Aphrodite goddess is the Greek goddess of sexual love, beauty, and can be considered as a counterpart of Poseidon. So now we have the Aphrodite criteria for men with infertility. A bit of background, why did we talk about developing the Aphrodite criteria? Why did we think it was important? Well, with the Aphrodite criteria, we want to really standardize the approach to classify male patients with infertility, not only for natural conceptions, but also for ART trajectories. We want to improve communication, clinical management. In male infertility, often there are several specialties involved: urologists, endocrinologists, fertility specialists, gynecologists, andrologists, and when we have a similar set of criteria, we can really optimize communication and clinical management of patients with male infertility. We also hope that the Aphrodite criteria can help us highlight areas that lack data and that can benefit from clinical research, and that they can also promote clinical research by really identifying groups of men that could potentially benefit from pharmacological treatment options, either new treatment options or repurposing older or already existing treatment options. So for the Aphrodite criteria, the classification is based on clinically relevant laboratory data. So we use semen analysis as a first step, but we go beyond semen analysis, and I think that's really important when you evaluate men. Don't stop after getting back the semen analysis results. Also look at genetics, at hormones, etc. And for the Aphrodite criteria, we also incorporated FSH levels and testosterone levels. So for the semen analysis, we use the FWO criteria, latest version published in 2021, to classify men with normal semen analysis, altered semen analysis, or azoospermia. For FSH, we classify men with either elevated FSH or normal or low FSH based on the laboratory reference ranges that you use. And for testosterone, we decided to put a cutoff for total testosterone on above or below 350 nanograms per deciliter or above and below 12 nanomole per liter to identify men with normal testosterone or reduced testosterone levels. And so based on these three factors, we made 5 Aphrodite groups. First group is our men with hypogonadotropic hypogonadism, can be acquired or congenital. Second group is men with altered semen parameters, FSH levels within the normal range, and also testosterone that is normal. The third group is a variant of group 2, where FSH levels are also in the normal range, but testosterone levels are reduced. And then group 4 is men with elevated FSH levels, with normal or reduced testosterone levels, and group 5 are men with idiopathic or unexplained infertility. So normal semen parameters, normal hormonal profile are fitted in group 5. Now, if you have a look at the different Aphrodite groups in more detail, starting with group 1, the hypogonadotropic hypogonadism patients, we know that there's reduced spermatogenesis due to reduced gonadotropin production or action. There's both a decrease in sperm production, either azoospermia or severe oligospermia, combined with low gonadotropin levels and low testosterone levels. Luckily for these men, we have good data on treatment, and they can benefit from treatment with gonadotropins, a combination of FSH and ACG that is mostly used to increase their sperm parameters, sperm retrieval rates, and most men in this group can father a child. It's quite a rare condition. About 1 in 8,000 men have hypo-hypo when we look at the prevalence of congenital hypogonadotropic hypogonadism. The second Aphrodite group is the men with altered semen parameters, but FSH levels and testosterone levels in the normal range. So if you look at their definition and characteristics, we can see that they have no clear cause of infertility. So it's really men with idiopathic infertility, with normal clinical and endocrine evaluation, but with an altered semen analysis, so suboptimal sperm parameters. And these patients really have, although they have a decrease in sperm production or sperm count, their FSH levels are still normal. So we think they have a reduced gonadotropin action. So they have like an image of functional hypogonadism with FSH that is not stimulating spermatogenesis in these men. There are some data that these men can benefit from FSH treatment, and that this can improve sperm parameters and sperm retrieval rate in case of azoospermia. And we think that based on literature, that 30 to 40% of men with idiopathic infertility can be classified in this group. The third group is a variant of group 2. These are men with altered semen parameters. FSH levels are in the normal range, but testosterone levels are reduced. So this is also an image of functional hypogonadism, now not only on the spermatogenesis part, but also on testosterone production part. There are also some data that these men can be treated with gonadotropins, FSH combined with ACG, and that this can increase or support better sperm production and sperm retrieval rates. From literature, we think that 10 to 20% of men with idiopathic infertility classify in this case. In this group of Aphrodite group 3. We had some analysis done in our patient group in a retrospective way, and we see that most men with obesity fall in Aphrodite group 3, so that this obesity really has an impact on their testosterone levels and potentially also on their spermatogenesis. For Aphrodite group 4, this is the most challenging group to treat because they have elevated FSH levels together with normal reduced testosterone levels. So this is really also a lot of patients with non-obstructive azoospermia that fall into this group. In our patient group, we found that 66% of men with azoospermia with NOA fall into Aphrodite group 4. And so they have very high FSH levels together with normal or low testosterone levels. It's actually not very clear if we can help these patients with gonadotropin therapy or with medical therapy. There are mixed results. People have tried a lot of regimens to improve their situation, to improve, for instance, sperm retrieval rates in patients with NOA. But that's still a question, how should we treat or support spermatogenesis in these men? And we think from literature that up to 10% of cases, male infertility cases classifies in this group. And then finally, Aphrodite group 5 are the men with unexplained infertility. So the diagnostic workup comes back normal. Hormonal results are normal. Testosterone FSH is in the normal range. Also no genetic finding, no varicocele, nothing. But they still have, and they have normal semen parameters. There the question arises, can we help these men by overstimulating their testes with FSH monotherapy, which is still an open question. We don't have any good data or good trials to support this approach, but this is a theoretical approach based on physiology, this can be tested. And from literature, the numbers of men with unexplained infertility varies, but will be around 15 to 40% of cases. So APHRODITE patients may benefit from gonadotropin therapy. We have good data in hypo-hypo patients, very good data in these men. There are some data supporting gonadotropin therapy in men in group 2 and 3, so with FSH levels within the normal range. For group 4 with elevated FSH and men with unexplained infertility, it's still an open question. How can we improve the situation of these men with medical treatments? So if we evaluate the male partner in the workup of the couple, we do blood testing. So don't forget to do the hormonal profile in these men. Look at FSH, LH level, testosterone levels, and based on these results, you can further stratify your approach. For medical treatment in men, you can treat men with hypo-hypo, so low testosterone, low LH, FSH with gonadotropins. And guidelines say that you can consider gonadotropin treatment in men with normal FSH and idiopathic oligozoospermia or OAT. And then take it into account medical treatment of men when you treat the couple. However, when we look at administration of FSH in men with idiopathic infertility, it's still an empirical approach. You can either substitute what's missing, like in the hypo-hypo patients, you give the gonadotropins that are not produced by the person itself, but you can also do a stimulation, an overstimulation, what you all know from treating females, to boost spermatogenesis beyond the physiological level. And so, in the final part of my presentation, I would like to go through some data that we have from literature about what about the results that we can obtain with FSH treatment in men with idiopathic infertility. This is results from an RCT already published 10 years ago, where they looked at increasing concentrations of FSH given every other day, and you can see that in the group that received the highest dose of FSH, so 300 units every other day, that they could increase sperm concentration after 3 months of treatment. There was also an impact on pregnancy rates, but you can see that the groups are very small, around 35 to 40 participants per group. But you can also see that pregnancy rates increased with treating the male partner with FSH, both spontaneous pregnancies and ART pregnancies. The number needed to treat for the highest dose group was 12 patients for a spontaneous pregnancy and 6 patients for an ART pregnancy. And important is that also when you continue using FSH treatment after these 3 months of therapy, but in the 4th month, 5th month, you could see a further improvement in sperm count, sperm concentration, but also motility and morphology started improving, and this effect continued after stopping the treatment. So 3 months after stopping therapy, there are still positive effects observed in this RCT compared to baseline values in these patients. Thanks to the Italians, we also have some real-world data on FSH application in men with idiopathic infertility, because in Italy, FSH is reimbursed in men with low or normal FSH levels. And here there are data from just under 400 men treated with either FSH alone or in combination with some other nutraceuticals or other endocrine therapies. And what do we learn from these real-world data? On the left side, you can see the baseline values of men treated with FSH, and then they are split up either men without follow-up visits or with follow-up visits. And then on the right-hand side, you can see the results of FSH treatment in men that have follow-up visits, that have follow-up data available, and these were about 240 men with follow-up data available. And there you can see that concentrations, sperm concentration and morphology improved with FSH treatment in these real-world data in Italian men, with an FSH treatment duration of about 5 months. And finally, there's also data from a meta-analysis looking at FSH treatment in men with idiopathic infertility. Here, important to say that the data included in this meta-analysis consists of very heterogeneous groups, not standardized. There's no standardization in treatment protocol, so that can influence the data. But in the final analysis, there was an increase in sperm concentration with FSH treatment. And there was also an impact on spontaneous pregnancy rate and pregnancy rate during ART, but you have to note that pregnancy rates was not the endpoint in most or none of the included studies, and also that the number needed to treat coming from this meta-analysis is high, so 10 to 18 men should be treated to achieve 1 pregnancy. So to end, I would like to highlight some key messages. Don't forget the male partner in the fertility workup of the couples because they contribute to the infertility cases. We know that semen quality is decreasing at an accelerated pace globally, so an andrological evaluation of the male partner is absolutely necessary. Gonadotropin stimulates spermatogenesis. We know that very well from physiology. And now the question is, can gonadotropin treatment in men? It has the potential to increase sperm concentration and pregnancy rates. And with the APHRODITE criteria, we really want to improve our knowledge, identify subgroups that can benefit from gonadotropin treatment. So hopefully we can better stratify our treatment options and select patients that really can have a beneficial effect of gonadotropin therapy on sperm concentration and sperm counts, and eventually also pregnancy rates, not only in ART, but also spontaneous pregnancies. Thank you.